presentation will be Dr. Catherine Otten talking about clinical presentations and manifestations of AFM and when to consider AFM. So Dr. Otten, if you're ready, let's go ahead and get started.
Thank you to Carla, Sarah, and Grace for inviting me today. I have the privilege of talking about the clinical presentation and manifestations of acute flaccid myelitis, essentially when to consider AFM. Brief disclosure, I do receive salary support and funding for work related to AFM surveillance from CDC. So in this brief overview, I'm going to cover briefly who's at risk for AFM, especially as we remain vigilant this season, discuss history, early symptoms, and early exam findings that might help clinicians understand how AFM will first manifest, and then summarize the assessment for an acute onset weakness presenting in a pediatric patient. And so of course, we're all here to talk about acute flaccid myelitis, this polio-like illness causing flaccid weakness or paralysis. I'm going to focus mainly again on the early clinical symptoms, but diagnosis of course is made based on not just the clinical presentation, but also laboratory testing and MRI demonstrating inflammation in the gray matter of the spinal cord. I hope to convince you that remaining vigilant and that early recognition is important, because this is a diagnosis we need to consider early on in our differential if we're going to anticipate potential worsening weakness, make sure that we triage patients to the right level of care. Early diagnosis helps us collect appropriate specimens and send appropriate testing, and consider what treatment and care options we have for patients. So who is at risk for AFM? Well, we know from data collected from CDC that the median age for patients in our last peak year, 2018, was 5 years old, but we've also seen cases in adults, especially if they're immunocompromised. And while we do see a peak in cases from late August to early November over the past years that we've been surveilling, this is definitely a diagnosis I would urge you to consider in any child at any time, and even in adults, because we know that, well, these are the most common features. It is not limited either to children or to the fall. This is data from CDC that I'm sharing, demonstrating, of course, that while there are peaks, there are still cases in any month, and so it is worthwhile to remain vigilant even outside of the peak times. What will you first see if you're meeting a patient who will ultimately carry the diagnosis of AFM? Well, we're going to go through the timeline, and I'm going to try and convince you that weakness and pain are not necessarily the first symptoms, but they are often the first complaints that bring a child to care. And that will often manifest as difficulty using a limb. And that may start in one limb, but it often spreads to one or more limbs. It is far more likely to be arm than leg weakness, but any limb can be affected or any combination thereof. And many patients will complain early on of pain. It can be either in head, neck, or even in limbs. I'm sharing a data table from the Lancet paper on diagnosis and management of acute flaccid myelitis that describes many of the manifestations of AFM. But to summarize, AFM symptoms go beyond just limb weakness, although that often is the reason why patients will be able to be prompted to seek care. The severity of weakness can vary widely too. That can be complete paralysis of all four limbs to more milder weakness in a single limb. But asymmetry is very likely. And this is a key, especially as you're examining a patient, because that asymmetry can help you identify weakness and hypotonia. Patients may or may not also have bulbar symptoms or facial palsies that can include drooling and difficulty managing oral secretions. And the vast majority will also have a CSF pleocytosis. And of course, by definition, gray matter spinal cord lesions are expected. I think there's nothing better than learning directly from a patient. And so here is a case example of a 7-year-old child ultimately diagnosed with acute flaccid myelitis. He was brought to care initially to his pediatrician due to parents noticing he wasn't using his left arm. They described an illness for 3 days prior with gastrointestinal symptoms, diarrhea, vomiting, and fever. But ultimately what brought them into their pediatrician's office was ongoing fevers, left neck shoulder pain, and of course this difficulty using his left arm. I've included quotes because I think these well illustrate the experience they had when first presenting. They noticed he was sick, but then I thought he was getting better, which is not uncommon when that preceding illness comes before weakness. They noticed it looks like he has no power in his arm. It was hanging limp. And they said, he said his neck hurt yesterday, but now he says his shoulder hurts. And I think this case well fits the average timeline. And of course, this can vary, but it's not uncommon in a week or so prior to have symptoms of viral illness. And it's been more commonly respiratory symptoms over gastrointestinal symptoms, but both are possible. That can include cough, fever, runny nose, sore throat, or as in this case, vomiting and diarrhea. Often patients will have sick contacts that they'll report, although they may have recovered while the weakness is emerging in our patient. In the day prior to presenting to care, neck pain and headache are not uncommon. And then of course, on the day a patient seeks care, arm or leg weakness is one of the most notable first complaints. And then of course, that possibility of facial weakness due to bulbar symptoms. And as I mentioned, early recognition and diagnosis can be key because in the day prior to onset of weakness, you'll also be monitoring for respiratory failure related to weakness, bowel bladder dysfunction, and then of course those bulbar symptoms. The acute and acute flaccid myelitis is also important. When we refer to acute, we mean that the weakness will emerge over hours to days. This timeline, of course, encompasses multiple days, but the weakness itself should be acute. It's not typically hyperacute though. So if you were to see a child with weakness over seconds, that would be less typical and may prompt you to expand your differential diagnosis. And most patients do experience progressive weakness, but it's also possible to have a stuttering course. When you first meet a patient with acute limb weakness, you're going to be performing a complete neurologic exam, but you can also use your history to help you identify the presence of weakness. And I like this graphic from CDC because it also includes questions to ask parents, especially in infants and toddlers where your exam can definitely be limited by cooperation. It can be really helpful to understand the family's perception of the child's functioning at home to help you hone your exam. And of course, while you're completing your neurologic exam, you're also rapidly assessing the presence of other findings like bulbar symptoms or axial weakness in case this is a child who does need additional respiratory support if they're not managing secretions well. And then, as I mentioned, using symmetry to detect abnormalities in tone, strength, and reflexes on your exam is key. And we'll go through a few exam moves that can be helpful, especially in young children, in identifying flaccid limb weakness. In our case example, I mentioned he presented to his pediatrician first, and his pediatrician astutely noticed that while his grip strength on exam was intact in that left arm, he was unable to lift his left arm above his head, and his pediatrician noted that it felt floppy, and he couldn't elicit reflexes in the left upper extremity while he could in the right. And this is not an uncommon exam. There are a few exam maneuvers that can be helpful, and this pattern of weakness, where it is more proximal weakness rather than distal weakness, is also more common in acute flaccid myelitis. And so exam maneuvers like grip strength, which really just look at distal strength, may not pick up on weakness. And so using exam techniques that also get at proximal strength and axial strength are important. If you're checking upper extremities, you can ask the child to hold their arms up like this young man in a wing formation and use your strength to test against theirs. And of course, you're comparing sides. You can use push-pull testing have them make a muscle like this child here, and then use your strength against theirs in confrontational testing. And simply have them raise their arms all the way above their head. In the case of this child, it was the case example, it was noted that even coming in the door, he wasn't able to lift his left arm the same way he could his right. You'll also want to check for axial strength, and that can include checking head and neck control, head and neck flexion, checking their core strength. You can have them touch their toes and then bring their arms up into the sky in play-based testing if it's a child who can't comply with direct confrontational testing. For lower extremities, you can have the child get up out of the chair, up out of the exam table, and do hip raises or do pretend climbing stairs to demonstrate that hip function. You can have them squat and then stand. And then again, you can do confrontational testing with a push-pull method in their legs. Another key feature in acute flaccid myelitis is, of course, that flaccid portion. And that flaccidity can manifest with either hypotonia or hyporeflexia. And so checking reflexes is a really key portion of your assessment early on as you're considering acute flaccid myelitis in your differential. You'll be looking for reduced reflexes. And so comparing each side to ensure that you know what normal is for that child is helpful. You can, of course, have bilateral involvement, but because many patients are asymmetric, this is a helpful tip. You'll feel for tone by feeling passive movement of the child's limbs. You'll ask them to relax like a noodle or relax like a jellyfish to make sure that you're truly testing their tone and not inadvertently testing their strength and eliciting paratonia. So you'll have the child relax and then manipulate the limb to feel that underlying tone. And again, we're expecting low tone as evidence of that flaccid portion of flaccid myelitis. And just to review again, symptoms beyond limb weakness can be present. And so both history and exam assessment for cranial nerve dysfunction is key, as just around half of patients may have this depending on the year. Patients may describe drooling, or you may notice difficulty with managing their secretions. You can notice facial palsies. You can have them do forceful eye closure, gritting of their teeth to assess for the presence of asymmetry or weakness. They may have slurred speech or dysarthria or double vision. Bowel and bladder symptoms are also not uncommon, although not present in every patient, especially at onset. But you'll ask about urine retention, constipation, or incontinence, and checking post-void residual may be appropriate. Sensory involvement is also possible, although I placed an asterisk by this as it is not present necessarily in the majority of patients. And if sensory involvement is one of the most overwhelming symptoms present, you really should be thinking beyond acute flaccid myelitis in your differential too. These can manifest as paresthesias or numbness. And then, of course, additional autonomic dysfunction is also possible, and monitoring vital signs or blood pressure, temperature, or heart rate changes is important. Circling back to our case example. So fortunately, due to the vigilance of this child's parents and pediatrician, he was emergently directed to major hospital's ER for assessment, and ultimately that same day was able to undergo a spine MRI and lumbar puncture that helped him receive his diagnosis of acute flaccid myelitis and get hospitalized and treated immediately. I would be remiss if I didn't cover symptoms that are not classic manifestations of acute flaccid myelitis too, to make sure that we are considering AFM in our differential, but also retaining an appropriate differential. If you're seeing a patient who has a more distal pattern of weakness, especially if it's ascending weakness as well as hyperreflexia, you'll also be considering Guillain-Barré syndrome. If there is encephalopathy present, and that could be cognitive or behavioral symptoms, you'd be thinking about acute disseminated encephalomyelitis, or ADEM. And again, if it's hyperacute, meaning occurring in seconds rather than, as we expect in AFM, minutes to hours, you might be considering vascular causes such as a spinal cord stroke. If symptoms are isolated to cranial neuropathies or predominantly cranial neuropathies, you may also be thinking of a brainstem encephalitis. And if a child's age is under 5 months, that's less common. And so while you can consider AFM, you'll also be considering other causes of acute paralysis. And for patients with seizures, also would not be an expected manifestation. And so you'd be thinking about autoimmune or infectious encephalomyelitis. And if there's the presence of vision loss, then you'd also be thinking about other myelitis, including an acute demyelinating event like a transverse myelitis with optic neuritis. So in summary, I hope I've convinced you that if you're seeing a patient with acute onset of flaccid limb weakness, you should definitely be considering acute flaccid myelitis. And we'll be monitoring for this, especially in young children and immunocompromised patients in early autumn, but considering it in any patient at any time presenting with flaccid weakness. And while limb weakness may be what brings a patient into care, it's often preceded by illness and pain. As you assess these patients, you'll be monitoring for low tone, asymmetric weakness, and depressed reflexes. And monitoring for other associated symptoms, especially respiratory effort, secretion management, cranial nerve palsies, autonomic dysregulation, and sensory involvement, which invariably may or may not be present. And in patients for whom AFM is on your differential, consider emergency evaluation so that they can get rapidly diagnosed and triaged appropriately. Thank you again for inviting me. Thank you to the AFM working group. Thank you to my colleagues across multiple disciplines who help care for patients and families with AFM. And of course, thank you to patients and families who have experienced AFM from whom we continue to learn.
Great. Thanks so much for that thorough overview of the presentation of AFM and the initial evaluation, Dr. Otten. We do have the chat open, so if any of our attendees have questions for Dr. Otten, please feel free to enter those questions in the chat, and we'll make sure they get asked. So I did have a quick question. Who do you think? So in most cases, or often at least, we have someone without a lot of experience in AFM as the first person to evaluate the child. Can you maybe share how you've been working in Seattle to make sure that the first line providers who see the patient are familiar with AFM and have an idea about the basic evaluation?
Absolutely. You're very right. A neurologist is not the first person who meets a patient presenting with acute limb weakness. It's often pediatricians and then referring on to our ER. And in the Children's Hospital where I work, we've done outreach and education with our ER providers too, to make sure that AFM remains on their differential and make sure that they know the exam techniques that can help them rapidly understand if this is a flaccid limb weakness. Help distinguish from some of the other major emergency scenarios, such as an infarct, such as an acute demyelinating event, or an infectious myelitis. And to hopefully get a neurologist involved early on as well, so that we can help complete a thorough neurologic exam too, and help guide any further testing that might be necessary. Especially in patients presenting with limb weakness in a younger age, getting the patient up and out of the exam bed is often really, really helpful, and getting them to move around in the clinic room or in the ER examination room is often the only way that you can detect weakness if it's not full paralysis of a limb. And so we've been working a lot as teams in neurology in the ER to make sure that we're not just assessing distal strength as we might in a patient lying down or seated, but getting them up and out so that we also pick up on proximal weakness if it's present.
Great. That sounds good. I've got a couple of questions here, and I think they should be pretty quick. Dr. Mararu asks, I might have missed it, but the classical presentation of AFM starts immediately after the commencement of the respiratory GI viral symptoms or during the viral syndrome? Question. Or is there a lag of a few days?
Great question. It could be either. And I think we've all seen patients for whom there haven't been a preceding viral symptom that is identified either. So while it's helpful when that's present, the timing can be variable. And if it's not present, that doesn't mean that the patient isn't experiencing acute flaccid myelitis. I've certainly seen patients for whom the fever was a week or even more ago, and in patients for whom they are still febrile at the time they present with their weakness.
Yep, as have I, agreed. So the next question, what is the role of lumbar puncture when approaching a patient with AFM? We may get more of this in the next talk, I'm not sure.
I will defer a lot of this to Dr. Wilson-Murphy, but absolutely the presence of CSF pleocytosis is a really helpful feature to confirm that there is truly an itis, that there's inflammation present, and that it's myelitis rather than, say, a myelopathy. And I know we'll hear more from Dr. Wilson-Murphy next.